This is a basic outline of where we're going in the talk today. We'll start out talking about some developmental abnormalities. So these are inherited conditions, right? So who do you think is going to get those? Younger people, older people? Usually younger people, because they tend to be inherited and they'll present in younger people. The acquired disorders of bone are going to be seen more in older adults, and then we'll end up talking about some tumors of the bone. So as we go through this first part of the talk, I really want you to kind of pay attention to the mechanisms behind these developmental disorders. So there are a whole bunch of them, but if you think about what can go wrong in bone formation, this is going all the way back to embryology. There is a lot of steps, right, that happen in the migration of cells, and you have transcription factors necessary. You have to have proper signal transduction as you're going through. So any abnormality on any of those steps along the way will lead to disease. Okay, so just general terminology. Dysostoses, that word refers to a localized problem in the bone. So it's usually due to abnormal migration of the mesenchymal stem cells, but this is going to be a problem that's just in one area of the body. So syn polydactyly, which we'll look at, would be an example of that. As opposed to dysplasias, these tend to be problems like in collagen, for example, and collagen is important in all the bones of the body. So dysplasias are going to affect all your cartilage and bone throughout the body. This chart you can review on your own when we're done here, but these are essentially the diseases that we'll talk about. Just so you know, there are a whole lot of metabolic diseases in bone. We're just focusing on the more common ones and the ones that are good examples of each of these pathways here. So this first one here, the syn polydactyly, that's a good example of dysostosis. Everything else on the chart is going to affect all of your skeleton diffusely. So everything else here is a dysplasia. So starting out with abnormalities here in nuclear transcription factors, you remember the homeobox genes are really important in bone formation embryologically. So when you have mutations in homeobox D13, it's a transcription factor, and you get abnormalities in bone. So syn polydactyly is one example of that, and here is a baby with it. So syn tells you it's fused, right? And polydactyly, there's an extra finger. So there's an extra finger usually between your middle finger and ring finger, and it tends to be fused. Now, some of the other mutations in homeobox genes can also give you extra fingers. You can get extra ribs. And brachydactyly is just when you have short fingers and toes. So essentially, any of these transcription factor things are going to be localized usually to your extremities. So let's contrast that now with a problem that affects the signal transduction pathway of bone. So achondroplasia tends to be the most common skeletal dysplasia, and it's the number one cause of dwarfism. So before we look at the clinical, we're going to go into the mechanisms here, and we'll come back. So in most diseases, I really think if you know the underlying pathophysiology, you can pretty much predict what's going to happen. You can predict the clinical. So in this case, the problem is in fibroblast growth factor receptor 3, and you've got activation of this receptor. So let's talk about normal. Normally, this fibroblast growth factor receptor binds to fibroblast growth factor, and it inhibits proliferation of cartilage at the growth plate. Okay, but in a normal person, that's not going to happen all the time, right? So the problem in this is you have a mutation in the receptor making it active all the time, and therefore the chondrocytes cannot proliferate at the growth plate. So what will happen if your growth plate cannot proliferate? your bones won't grow, right? And that's essentially what you see here in achondroplasia. So, the growth plates are important here, right? In your limbs, that's where you get endochondral ossification. So if you think about what's going to happen in these kids, they're going to have short limbs, and they're going to have a relatively normal length of the trunk, because cartilage is not necessarily the way that your trunk grows, right? And they get relatively large heads. They can have some protrusion of the forehead, some depression of the nasal root. But these patients have relatively intact intelligence, and they live a normal life. So this is as opposed to the next form of dwarfism, which we'll talk about. This is thanatophoric dwarfism. This is a lethal form of dwarfism. And you can see this is an autopsy of a baby that, most of these kids are not going to survive, right? So the problem is still the same. It's in the fibroblast growth factor receptor. It's an activating mutation, but this is a different mutation than the one we looked at for achondroplasia. But in this case, you're going to have, again, micromelia, which refers to really short limbs, a head that's big. And the other thing that happens here, which is what makes this lethal, is that the chest doesn't grow. So they have a really small thoracic cavity. And if you remember from your embryology, your lungs, are not going to grow properly if you don't have space for them. So these fetuses are born with really tiny lungs, and that's incompatible with life. So the next group of diseases we're going to talk about is osteogenesis imperfecta. And the leading problem here is a deficiency in type 1 collagen synthesis. So just knowing that, you should really be able to predict what is going to happen to these people. Okay? So where does type 1 collagen exist in the body? It exists in the bone, so they're going to have really fragile bones, very prone to fractures. It exists in the ossicles of your inner ears, so they often have deafness. It exists in the sclerae, right, of your eyes. So we'll look at an example of what happens there. The dentin in your teeth often has type 1 collagen, so they tend to have these short, kind of shrunken teeth. And then the skin, like the dermis in your skin, collagen is present there too, so they have really fragile skin with easy bruising. Now, I had a patient with osteogenesis imperfecta on my pediatrics rotation as a medical student. It was a very interesting case because she came in with bruising on the skin. She had fractures of her ribs and of her arm. So what's the first thing you think about as a pediatrician when you have child abuse? Exactly. And that's something you always want to rule out, right? So we're going down this pathway thinking we have to contact Child Protective Services, and somebody dug in deeper and found that this had been a recurring problem for her. Ever since she was like 2 months old, she had these fractures, right? And now that could still be child abuse over time, but it kind of makes you think, why does she have this for such a long period of time when the parents seem like they're not the typical pattern of child abuse? Although there isn't really a typical pattern. But anyway, so we had to dig in deeper based on the history. Genetic testing was done, and she ended up having osteogenesis imperfecta. And that was a case that really kind of burned this into my mind. So often, sometimes at least, this gets confused with child abuse if you're not thinking of the underlying problem. So we talked about the tissues that will be affected. And there are 4 different subtypes of osteogenesis imperfecta. I really don't think it's necessary for you guys to know all the details of the different types. Just know that the type 1 form is the one that is really the least severe. These kids tend to have normal lifespan. versus the type 2, which is the one that is the most lethal. This is incompatible with life. The ones in between are kind of intermediate. And this is kind of what happens in the type 1, 2, and 3 forms of the disease. So the sclera, we talked about the fact that the collagen's not forming properly in the sclera. So the sclera is thin, and so you're seeing the choroid behind the sclera. So that's why it looks blue. It has a very kind of, it really pops out, clinically. All right. So here are some other examples of a baby with osteogenesis imperfecta. You can see there are multiple fractures all over the place here because the bone is fragile, right? The collagen isn't working correctly. There can be deformities in the limbs. This is a child with scoliosis, kind of this S-shaped curvature because the spine's too soft. So any questions about osteogenesis imperfecta? And you guys can interrupt me at any point as we're going through here. So next we're going to talk about osteopetrosis, which is sort of an opposite problem to osteogenesis imperfecta. Osteopetrosis, they get really sclerotic, thick bones, but the bones are not normal. Okay, so sometimes they call them like chalk-like bones, okay, because it's hard, but it's very brittle. So osteopetrosis refers to stone-like bone, and the underlying problem, there are again different forms of the disease, but the one that we know best has to do with abnormalities in carbonic anhydrase 2. Now, you guys may not have had a chance to review Dr. Ream's materials, but I recommend that you do that at some point before your final. Your osteoclasts work by having proton pumps, right? They get the protons out in the resorption pit, and that is what helps in the digestion of bone by osteoclasts. So the reason we're pointing that out is because if you have deficiencies in this enzyme, your osteoclasts cannot excrete the protons into their resorption pit, and the bone cannot be reabsorbed. So this is the best characterized form of the disease. And as you would expect, if you cannot have osteoclasts working correctly, your bone becomes too thick and sclerotic. So this X-ray is showing you this kind of white, really super thick cortex. And part of the problem here is that the cortex just keeps growing and growing. So normally in long bones, you have that medullary cavity, and that's where all your hematopoietic cells sit, right? So in osteopetrosis, if you have this cortex growing all the way through, you don't have room for your normal hematopoietic cells. So what do you think is going to happen to your patient when you see this patient? If you do blood work, all the cells are going to be low, right? They're going to have pancytopenia. They may present with infections because they don't have enough white cells to fight off infections. They may have bleeding, bruising from the platelets. They may be anemic, right? So pancytopenia can be a sign of this problem. And they can also present with fractures because these bones are quite fragile. If you get the sclerosis right around your neural foramen, you can get cranial nerve defects. And the X-ray is actually quite characteristic for osteopetrosis. I have personally never seen a case of this, but they call this the Erlenmeyer flask deformity. So you can see kind of at the distal ends of your radius and ulna, it kind of flares out, right? Your bone kind of flares out, and that's considered to be kind of characteristic of osteopetrosis. So that was it for our genetic kind of conditions. All of those happened in really young people. So now we're moving on to the disorders that you're probably more likely to see because these are more common. They happen in adults. The first one we're going to talk about here is osteoporosis. So I would say this is probably the most important section of my talk, only because you're all going to see somebody with osteoporosis, and I want you to know the mechanism behind it, which will help you take care of these patients and treat them. So as you know, osteoporosis refers to the fact that there is less decrease in bone density. So your bones are fragile because there isn't enough mass, and because of that, you're predisposed to getting fractures. Osteoporosis can either be localized, so a patient who is bedridden from surgery, if they don't use their limbs at all, they can get disuse osteoporosis. That's a less common form, but that's part of the reason you prescribe physical therapy for your patients after, some kind of limb surgery, right? You don't want the bones to kind of wither away. And then the more common form, and if we don't specify, this is what most people are talking about, is the generalized form of osteoporosis, which is going to affect most of the bones in your body. And the two principal settings where this happens is with increased age, so age-related, and postmenopausal. So we'll look at the mechanisms of that. And then the secondary osteoporosis, this refers to people who have a primary problem somewhere else, like hyperparathyroidism, for example, and because of that, they end up losing bone density. So you're going to get more of this as you go through your endocrine course. We're going to focus on this more common primary generalized form of osteoporosis. So most of you are going to achieve your peak bone mass sometime in the near future. I assume you're probably in your early to mid-20s. So by 30 is really where you reach your maximum bone density. And every year after that, you normally end up losing a little bit of bone. So this is the normal aging process, and you have a lot of variation in which you lose bone. So the normal density of bone kind of depends on genetic factors, and you also have other environmental things that affect it, right? So age, we talked about. The more active you are, especially with weight-bearing sorts of exercises, the more stress there is on your bone, and the more likely it is that your osteoblasts are going to keep laying down more bone. So people who are more active, when you use those bones, it's more likely for them to be denser. So this is part of the reason why you tell your patients to continue doing weight-bearing exercises as they get older, because you want to kind of avoid that disuse osteoporosis. Nutrition, you need vitamin D and calcium. Those are important calcium is like the main mineral in your bone. So again, postmenopausally, we usually prescribe vitamin D and calcium for our patients to kind of avoid that. Women tend to have less dense bones than men. So osteoporosis is something that we normally think of happening more in women than in men. African Americans tend to have denser bones than Caucasians. And then the genetics, it runs in families. So this is a view here of an osteoporotic spine. This is at autopsy. And you will see here that the vertebral bodies there's a lot of space here between the trabeculae, right? And the ones that are actually left here, so normally when you cut into the spine, this is pretty thick. Like you'll see horizontal trabeculae and vertical trabeculae. And in this case, you've lost all those horizontal trabeculae. And that's usually what happens in osteoporosis. So why do you think that might be? Why would you preserve the vertical and kind of lose the horizontal stuff in the spine? Exactly, it's stress related, right? Because most of the weight on the spine is going up and down. So these tend to be used more, and you tend to lose this first. So now this is a figure directly out of Robbins, and we're going to talk about the physiology of aging and menopause-related osteoporosis. So let's start with postmenopausal. Estrogen normally helps to keep the pro-inflammatory cytokines down in the body. So when you lose estrogen postmenopausally, it leads to increased synthesis of certain pro-inflammatory cytokines in your liver. So when you get these cytokines, they cause increased expression of the rank ligand on your osteoblasts. This is again from Dr. Ream's portion. You may have learned about this last year. But that's the rank ligand on osteoblasts is what binds to the rank receptor on your osteoclasts, and that's what activates your osteoclasts, right? So if you have less estrogen and you've got more of this rank and rank ligand, you're really stimulating your osteoclasts to work more. This is a increased kind of bone loss, increased turnover state causing osteoporosis postmenopausally. Now this, we're going to compare that to aging. As we get older, our osteoblasts don't work as well. They synthesize less collagen than they would have otherwise. You know that enzymes don't work that great with time. So over time, your growth factors and enzymes are not going to work as efficiently. Often you have decreased physical activity with age. So all of that together can result in decreased bone formation, resulting in osteoporosis. So aging is a problem with decreased synthesis of bone versus menopause, which is a problem with too much loss of bone. But what you see in both of those is going to be the same. The parts of the body that are most affected tend to be the spine, the pelvis, the femoral head. Those are kind of where the process usually starts. So here's a patient who has these compression fractures in the vertebrae, and you can, so clinically, they're going to lose height because of that. If this happens around the thoracic vertebrae, they'll be predisposed to getting pneumonia, right? You can have fat emboli depending on where the fracture happens. You can get pulmonary embolism as a complication of this. So this can be a really big deal. And this is really why you get, like if your grandma slips and falls in the snow, she's more likely to break her hip than you are, right? And that's because of the postmenopausal and aging-related changes that happen in the bone. And I had a patient who had osteoporosis. That was not her primary problem. This was when I was a Path resident, and before we did bone marrow biopsies, we were told to practice on our cadavers. So at autopsy, we had to do the bone marrow biopsies, and we had like a certain number you had to do, and then they let you loose on actual patients. So the very first patient that I had to do this on was, mid-80s, a really nice lady, and we thought she had myelodysplastic syndrome, which you may have learned about in heme, but that's not the point of what I'm telling you. She asked me while I was getting ready to do all of this, how many of these have you done before, doctor? And I was just like, oh my gosh. You don't want to lie, right? You don't want to say, oh, I've done hundreds, but you don't want to tell her this is your very first one, because no one wants to be the guinea pig for you. So I'm sitting here thinking, what am I supposed to say? And thankfully, the nurse practitioner who was kind of guiding me through this took over and said, oh, I've been doing this for 30 plus years, and I'm going to watch her all the way through. It's like, thank God for that, because I don't know what to say to that. And so while we were practicing, we were told, that you're going to kind of hear the bone pop as you go through the cortex into the marrow cavity, and you have to push really hard to get through. We're doing this in the posterior iliac crest area, so I'm all ready to push really hard, but it was so soft, it just went right through because her bones were osteoporotic, and it was not the typical situation. But I hate doing bone marrow biopsies. I hope I never have to do another one. Yes? Yeah, I think pneumonia, We tend to think of patients who get older, they get pneumonia more because they don't breathe deeply, and they tend to get more mucus and secretions and stuff getting trapped in your bronchi, and then that predisposes you, that's like a setting for infection. So that's usually what I think about. Osteoporosis, especially people who have fractures in the thoracic vertebrae, they can get further compression of their lungs, which can predispose them. But you're absolutely right. Most patients, anyone who's hospitalized, we tend to think of them as being at higher risk of developing hospital-acquired pneumonia. All right, so we're moving on now to Paget's disease. Paget's disease, I think, is really a very interesting disorder. It was first described in the 1800s by Sir James Paget, and therefore it was named after him. And he thought it had to do with inflammation. So he called it osteitis deformiens. We now know that is not the case. So I like to think of Paget's disease as too much of everything. So they call it matrix madness. You have too much osteoblastic activity, they're laying down bone. You have too much osteoclastic activity, reabsorbing the bone. And the net result of all of this can be too much bone, but it's abnormal. So it's kind of a common theme that we're seeing in some of these diseases here. It's architecturally flawed bone, and it is more likely, therefore, to break and fracture. So I kind of skipped over this part, but this is the other interesting thing about Paget's disease. If you did epidemiologic studies, you would see that it's more common in certain parts of the world than in others. So it's common in the United States and parts of Europe, and much less common in parts of Asia and Africa. So Paget's is usually a disease that we think of as affecting Caucasians. So we are still trying to figure out what's the underlying problem here. So we think there is a genetic factor to it, and there's clearly an environmental factor here too, because it seems to have some geographic variation. But anyway, so here's a patient with Paget's disease. He has this really classic kind of facial appearance. They call it the lion face or liontiasis faciae. Again, I have never seen a patient with this clinical appearance, but it's very classic looking. And this happens because with all this matrix remodeling, you get enlargement of the craniofacial skeleton. And the other problems that you can have in patients with Paget's, it depends on how much of the bone is involved, right? Most people have involvement of more than one bone. Paget's tends to involve kind of the axial skeleton more than your appendicular skeleton. So it involves your skull, your spine, your pelvic bones, much more than it does your humerus, tibia kind of bones. Actually, a lot of patients who initially present with Paget's may be asymptomatic, so this may be something that just gets picked up by radiography. When it's advanced, that's when you start seeing these changes. And then when the bone is brittle, you know it's going to fracture, and we can get secondary osteoarthritis as that fracture happens around the femoral head. So the other problems, the other complications of Paget's disease, the most dreaded complication here is osteosarcoma. So 5 to 10% of patients who have Paget's in multiple bones are prone to getting osteosarcoma. So these people really have to be scanned carefully over time to make sure we don't miss this. The other problem that can happen with all this osteoblastic clastic activity, you get a lot of vascular supply to that area. So you get kind of dilated, increased vascular proliferation. And this almost acts like an artificial arteriovenous shunt. So the heart has to pump really hard because there's too much volume going into these increased vessels. So this is high output cardiac failure. That can be the other complication of somebody with Paget's. Here you can see the cranium, it's thick, and the periosteum is showing you the hypervascularity. These are the 3 phases of Paget's disease. The first phase is the lytic phase. The radiograph is showing you that this way. The diagram is going from top to bottom. So in the lytic phase, you get too many osteoclasts. And just a brief review of histology, you guys all remember this, I'm sure, but osteoclasts are the multinucleated cells, right? So they are the ones that come from like your macrophage precursors, as opposed to osteoblasts, which just have a single nucleus. So if you're ever shown a histologic view, that's kind of how you'll tell them apart. But anyway, the lytic phase has too much osteoclasts kind of burrowing into the bone, causing holes. So you're seeing that here. Then we have the mixed phase where now the osteoblasts are coming in to kind of, they're reacting to the loss of bone. And so you get both sclerosis and lysis of the bone. And finally, we're in the sclerotic phase, which is where it ends up. This is kind of burnt out sclerotic bone, where now you just have too much bone, but it's woven bone. It's not properly mineralized. It fractures easily. This is a very classic histologic appearance. If you ever see anything with all these kind of wavy lines within the bone, it's most likely going to be Paget's disease. They call it like a jigsaw puzzle-like look to the bone, because you see all these kind of wavy lines in here. It's because the bone tends to have microfractures, and then when it heals, it anneals with these cement lines, which is what makes it look like this. All right? Yes? Yeah, that's an excellent question, and I don't really know the answer to that. So some of the other diseases that we've talked about so far, I guess I would say in Paget's, the underlying mechanism, we don't completely understand it, but it seems like you do have a proliferation of osteoblasts, and perhaps if those osteoblasts acquire more mutations over time, that can predispose you to getting osteosarcoma, as opposed to, what we've talked about so far has been osteoporosis. We've talked about some of the genetic things. But that's not the perfect answer to your question. I don't think we know the answer to that. Yes?
You mentioned the environment required for osteoclasts. Well, here we have both osteoblast and osteoblast. What would you categorize?
Another excellent question, and I don't know the answer to that. I think it, so this happens in different phases. I will say that in stage 1, it is probably more of an acidic milieu, because you've got osteoclasts kind of burrowing into the bone, and they are functioning here. So this is probably acidic. Now, in stage 2, I don't know, because you have both osteoclasts reabsorbing and osteoblasts laying down bone. And then in stage 3, you don't see osteoclasts here anymore. So I would say this is probably no longer resorption pits you're not going to see anymore. All right. So here's your first review question. We'll do the show of hands thing again, because I did not do the clickers. So we have a 60-year-old lady, hip fracture. Here's her x-ray. So what is her disorder, first of all, you think? So she's got a fracture here. She's got osteoporosis, because if you look at the thickness of the bone here, it's just too black, it's too dark. There isn't the whiteness that comes from the bony trabeculae and calcium, right? So she has hypodense bones. Now, this could be either aging related or it could be postmenopausal. So I would say this is probably more likely to be postmenopausal, but it certainly could be either. And then to answer this, okay, so let's just go through how many people think it's A? Right? What about B? C? All right. Great. Okay, so yeah, so I think this probably is postmenopausal osteoporosis, and we talked about how that's an increased bone turnover state. So excellent. It is increased osteoclast activity with decreased bone density. Now let's talk about some of these other mechanisms here. Abnormal collagen synthesis, that's what we see in osteogenesis imperfecta. Increased osteoblast activity. I really haven't talked to you much about this. I guess Paget's in a certain stage you can think of as having that. And then decreased osteoclast activity. Again, we didn't really talk about that as a mechanism. All right. So these two things you're going to get more of in the endocrine course. So here we're just going to briefly touch on what happens in hyperparathyroidism. So you know the parathyroid hormone is important in calcium metabolism, and it does that in response to hypocalcemia. And the way parathyroid hormone works is, again, it works on that rank receptor and the rank ligand on your osteoclast, but it stimulates osteoclastic activity. So somebody with hypoparathyroidism is going to have too much osteoclastic activity, which will then cause bony resorption, leading to increased risk of fractures. Here is a pathologic view of what we call a brown tumor. This is in the rib of somebody with hyperparathyroidism. This is not a true neoplasm. We call it a tumor, but it's a mass. And the reason you get this is because you have, so the bones are fragile because of too much osteoclastic activity. They tend to break. You get microfractures. You get a hematoma. You get blood. You have fibrin. You get all the stuff, a mesh work of all of that together, and that makes it a brown tumor. We really very rarely see this anymore, and that's because most labs are going to pick up the abnormalities in calcium, and we tend to make the diagnosis of hyperparathyroidism much earlier than before they get to these changes. So here is if you were to do a biopsy out here, this is what you would see in somebody with hyperparathyroidism. So what do you think these cells are here? Osteoclasts, perfect, because they're multinucleated. They're sitting right around the bone, and they're eating it up. It's kind of this jagged outline. And so they call this dissecting osteitis in hyperparathyroidism. And this is what it looks like on X-ray. They call it kind of a railroad track-like appearance as the osteoclasts eat away the bone. But you'll get more about this in the endocrine course. And then renal osteodystrophy is the other, yes. Yes.
How is this acquired?
Yeah, so hyperparathyroidism, there are different forms. There's a primary form of hyperparathyroidism, which, again, we don't know what's causing it. You get a parathyroid adenoma or hyperplasia, which then results in increased parathyroid hormone secretion. And then you have a genetic form, which happens with these multiple endocrine dysplasia syndromes, MEN syndromes. You'll learn more about them as we go through, but the inherited forms are less common than the sporadic forms. So I would still say this is kind of a secondary problem in the bone because the primary problem is in your parathyroid gland. Does that answer your question? Yeah. Okay. So renal osteodystrophy, let's look at the mechanism of what's happening in these people. These are patients who have chronic renal failure. They cannot excrete their phosphate, and so they have phosphate retention. The hyperphosphatemia, the phosphate then binds to the calcium, and it leads to hypocalcemia. So increased phosphate and low calcium both serve as triggers to cause parathyroid hormone release. So the increased parathyroid hormone then stimulates your osteoclasts, and you end up having increased bone loss. So that's one way this works. The other way is the kidneys help in activating vitamin D. So when you have problems with the kidney, this conversion may not work. Without active vitamin D, you do not get adequate absorption of calcium from the gut. And so you don't get proper mineralization of your bone. So that's the other mechanism here. And finally, chronic renal failure predisposes you to metabolic acidosis. We talked about the fact that the more acidic the environment is, the more active your osteoclasts are, and so you tend to have more bony reabsorption. So people with renal failure, they often need vitamin D and calcium supplementation, and they are definitely predisposed to getting fractures because of that. Now, Dr. Barnett, who couldn't make it here today, had an entire lecture for you on fractures, which has been uploaded on Pilot. So I'm going to sort of run through this part kind of quickly. You know what fractures are. They, when a fracture heals, there are different stages to that process. The first thing that happens, you get a hematoma in that place. Blood vessels get disrupted. You're going to have inflammatory cells coming in. So that part, we call that a soft tissue callus. That happens usually by the end of the first week after your fracture. At that point, with all these cells that have come in, you get certain cytokines being released, which activate your osteoblasts and your chondroblasts. So at this point, you start having increased cartilage in that area. The osteoblasts start laying down woven bone. Okay, so this is the beginning of your bony callus. And the bony callus, just to start that process, it takes at least 2 weeks. So this is why when you have a fracture, you're told not to put weight on it because you don't have a proper mineralized bony callus that forms until at least 2 weeks after. So once you start getting proper endochondral ossification to heal that bone, you then finally end up in the last stage here, which is the remodeling phase, where the macrophages come in and kind of clean up any of the extra fibrous tissue at the edges. So the whole process together can take 3 or 4 months for the remodeling to be completed. But now that you know the mechanism of a fracture, how we treat it makes complete sense. So the reason you have to cast a fracture is because you want that soft tissue callus to actually mineralize and form that bony callus. So if you don't do that, if the bone keeps moving, then there's not enough time for the callus to properly form, right? So one of the complications of that, we call it a pseudojoint or pseudoarthrosis, which can happen there. You get non-disunion, delayed union. You are predisposed to getting infections, especially if it's a fracture that opens up to the skin. So, again, Dr. Barnett's talk, I'm sure, goes into all of this. The other thing that I think is interesting here is the things that inhibit fracture repair. And I think a lot of this stuff makes sense too if you think about it. Somebody who is not getting adequate nutrition, is not getting proper vitamins and calcium, is not going to heal the fracture as well. Somebody who has sepsis because of infection clearly is going to be predisposed to getting more problems with the healing. Ischemia, you're always disrupting the blood vessels in a fracture. So if you don't get enough blood supply to that area, it's not going to heal properly. Patients with diabetes are prone to having problems with healing, not just in the bone, but really they get chronic wounds, which also won't heal because they have vascular issues. All right. So moving on now to avascular necrosis. Avascular necrosis, as the name implies, is dead bone because there isn't enough oxygen to it. So it's decreased vascular supply, and that can be for a whole number of reasons. Fracture, which we talked about, corticosteroids due to some unknown mechanism, can predispose you to getting avascular necrosis. So a lot of your hospitalized patients, when they're on IV corticosteroids long term, they will be predisposed to getting this. And the patient's going to present with like sudden onset of usually hip pain. And the most common site for this to happen is subchondraly. So in the epiphysis, like the femoral head is a common place for avascular necrosis. And the other place where it can happen is in the medullary cavity of the bone. So let's look at, so here's somebody who had to have hip replacements done as a complication of avascular necrosis of the bone. Let's actually look at this picture here. This is the femoral head. It's a cross section. And this is showing you what an infarct looks like in the bone. You can see it's a wedge-shaped kind of triangular lesion. And it's white because it's dead. This is all necrotic bone. And at the edges of it, this red stuff, this is where the vessels are coming in to try to provide blood to this, but it's just not adequate, right? So this is a typical appearance of avascular osteonecrosis. And at the top, this white stuff at the top is cartilage. So the cartilage is still alive while the bone is dead. Why do you think that is? Why would the cartilage be alive? Yes, so it does not necessarily depend on the blood supply that comes through the bone, right? The synovial fluid provides adequate nutrition. So the cartilage stays alive longer than the bone. But as the bone dies, it can collapse over time. So the femoral head can compress down, and that predisposes them to osteoarthritis. So secondary osteoarthritis is a complication of avascular necrosis. Finally, we'll talk about osteomyelitis. A lot of this should be a review for you from your Principles of Disease course last year. Osteomyelitis talks about, the word implies that there's inflammation, which is true, but when we use this, we're usually talking about infection. So inflammation due to infection. And half of the times, we don't find the cause, the infectious cause for osteomyelitis. The vast majority of cases are due to Staph aureus, okay? But when you get a specific history, like an IV drug abuser, somebody who has renal infection, urinary tract infection, these patients are more likely to get infected with E. coli or Pseudomonas, one of your gram-negative bugs. Kids are more likely to get it because of Haemophilus influenza or group B streptococcus. Patients with sickle cell are more likely to get salmonella infections. You know the population that's most likely to be affected with TB. Syphilis is not something that is super common, but it's another cause of osteomyelitis. Now, there is a common theme here. This stuff should look a little familiar to you because we talked about this in the joints yesterday. So the same organisms that cause osteomyelitis can also cause septic joints. And it makes sense because the organisms from the bone can then just spread out directly into the joints, or they can get into the blood and hematogenously spread out into the joints. So this is a little view of what kind of the pathogenesis of osteomyelitis. In kids, especially when you see osteomyelitis, we think it's usually a hematogenous spread of the organism from little breaks, like just from brushing the teeth, you get bugs in the bloodstream. And those can, in an immunocompromised person, result in dissemination into the bone. Once the bacteria is in the bone, you're going to get neutrophils. Those are the first cells that respond. You get a whole bunch of neutrophils. You form an abscess. The abscess can then track all the way from the cortex through your haversial canals, and it can break out through the periosteum. So once the abscess breaks out into the periosteum, it gets into the soft tissue, and you can get a draining sinus. That's what we're seeing here. So all you may see is this hole with pus kind of coming out of it. because all the way down, you've got dead bone that's infected. So this is showing you this dead bone that's all necrotic. We call that the sequestrum, which is the dead bone down in the medullary cavity. And then you get new bone and blood vessels that come out around to try to heal, and that's called the involucrum. But osteomyelitis. Clinically, patients are going to be sick. It's a systemic infection usually, so they're going to come in with fever. They're going to have leukocytosis. Depending on the causative organism, and mostly it's bacterial, you're going to have increase in neutrophil count. It's very painful. Now, X-rays, they can be kind of nonspecific for osteomyelitis, honestly. If you have a really good radiologist, they can pick up on it early, but it can be very difficult. Here you can see that there is some thickening of the periosteum here, and you've got something going on in the medullary cavity. So, but this is not super specific in my view, but a good radiologist can probably pick up on that. So really to get a definitive diagnosis of osteomyelitis, you often have to get a bone biopsy. And once you get that biopsy, you send it to culture, and that is really the best way for you to grow the organism. Because if you just did a blood culture, which we often also do in somebody with suspected osteomyelitis, the chances of growing the organism are only about 50% out of a blood culture. Okay? So complications of osteomyelitis, if over time, this is true of any kind of chronic non-healing wound. You are predisposed to getting squamous cell carcinomas in those sites, and that's what's happened in this patient here. You are also predisposed to getting osteosarcomas and osteomyelitis that's untreated over time, and then complications just related to the infection. This is TB osteomyelitis. We talked about pot disease yesterday. It most commonly affects your spine. You can see that we've got an abscess that's necrotic. The bone is damaged, it has fractured, and it's compressing your spinal cord. So TB osteomyelitis tends to be much harder to treat than just regular pyogenic osteomyelitis. But again, you kind of have to do blood cultures and bone cultures to get to that diagnosis. Here's your next review question. All right, so we've got somebody who comes in with hip pain, fever, leukocytosis, kind of acute onset, so possibly infectious. Here's a peripheral smear. What are these cells? Sickle cells, yes. So good. So this patient probably has sickle cell anemia, right? So what is the most common cause of osteomyelitis in somebody with sickle cell anemia? Salmonella. And what is the Gram stain? Perfect. So it's a gram-negative rod, so D would be your answer here. So finally, in like the last 10 minutes, we're going to talk about bone tumors. Tumors in the bone are not super common, and when you try to categorize them, I want you to think about where in the body they're happening and the age group of the patient. That's really going to help you narrow down your differential for bone tumors. Bone tumors in general tend to be, you really need like a team of people to make the diagnosis and treat this patient. So when I did my fellowship in bone and soft tissue pathology, there are only 7 programs in the country that even offer that fellowship. So just so you know, this is not a very common thing for bone and soft tissue sarcomas to happen, and you need expert radiologists, orthopedic surgeons who specialize in sarcomas, radiation oncologists. So it's a big deal. If you get a patient with a weird sarcoma, you really should refer them out to a place that sees a lot of them. Okay, so with that, this you can review on your own. These are just some basic features of radiography, right? So bone tumors are not diagnosed in isolation. We start out with knowing the age and location. That's a clinical. You have to have a radiograph to kind of narrow down your differential. And then finally, we get the biopsy. We put it all together to come up with the diagnosis. So when you look at an X-ray for a bone tumor, ask yourself 3 questions. Is it well circumscribed? Can you draw a border around it? Is it involving the periosteum? So is the periosteum kind of thick? And is it confined to the bone or has it spread out? So those 3 things will kind of help you determine if the tumor is benign or malignant. These are the tumors that are more common in younger people under 30 and the ones that are common in older people. This chart will really help you with your differential and also knowing where in the body. There are certain tumors that happen in certain parts of the body, right? So as you're looking at this, really pay attention to osteosarcoma. It happens around the knee. Chondrosarcoma, most commonly, is an axial kind of central problem. So it happens in the pelvis, the spine, the ribs. So chondro is kind of more central. Now, the rest of these, I mean, just look through them. Enchondromas are kind of unique because they only happen in the small bones of the hands and feet. So, most of the rest of these are not on the hands and feet. Okay. So moving on, we have tumors that are benign. Benign tumors are much more common than malignant tumors, both in bone and soft tissue. We're starting out with osteochondroma. It's also called an exostosis. And this is the most common bone tumor. So if you see one, it's most likely going to be this one. The majority of the time, they're solitary, but there is an inherited syndrome. In the syndrome, you have mutations involving the EXT1 and 2 genes. These are genes that work on chondrocytes at the growth plate, and they are responsible for the enzyme that produces the heparan sulfate glycosaminoglycans at the growth plate. So if you have a mutation there, you're not making enough of the glycosaminoglycans, you don't get proper diffusion of your growth factors, and the cartilage cannot differentiate the way it normally would. So that's thought to be the mechanism for the inherited forms of this. Usually younger people. It is a slow-growing mass, often happens around the knee, and this is showing you this kind of, it's like a mushroom that just kind of comes off the surface of the bone, right? Most of the other tumors that we look at are going to be internal within the bone. This is one that happens on the surface. When you look at it, it has a cartilage cap. That's this grayish stuff. This is hyaline cartilage. And then this is your bony tumor below it. This is continuous with the bony cortex. So here is a histology of it. And this is the hyaline cartilage cap on top. Just underneath that, you're starting to form bone. This is woven immature bone. So this is part of the tumor. And then if you keep going down, here now you've got more mature bone and fat, right? So this is just, it's normal cartilage on top. It's got woven bone underneath it, and it just kind of fuses into normal medullary bone in the middle. So for a test, I would never give you just a histology view. You're going to get history. You will probably get an X-ray. So you're going to kind of put all of that together. The cartilage is not atypical, which is how you're going to tell that this is not osteosarcoma. So chondromas are another benign tumor of cartilage. There are 2 types of chondromas. There's an enchondroma, which happens within the bone, and this is the one that most commonly happens on the fingers and toes. Okay, and then there's the juxtacortical or periosteochondroma, which can happen on the surface of the bone. So here's an X-ray. If we practice our 3-question test here, this is on the finger, so you know the location. You know, is it well circumscribed? I would say it is. I can draw a border here. Is there periosteal involvement? Not really. And does it spread out into the soft tissue? No. So all of those things tell you this is probably a benign lesion. And so this is an enchondroma. You wouldn't know that until you actually did a biopsy and saw what it looked like inside. Now, there are certain syndromes. You don't need to know the details of the syndromes. It's just that an enchondroma in itself is a benign lesion. It does not progress into chondrosarcoma. But in patients who are unlucky enough to have these syndromes, they are more predisposed to getting chondrosarcomas. Their enchondromas look more atypical, and they can transform into chondrosarcomas. So this is what it looks like under the microscope. It's just hyaline cartilage. It's a mass of hyaline cartilage, and this is where it intersects with the bone. You can see there's a nice border. It is not infiltrating into the bone. So this is a benign tumor. We cure it just by cutting it out. Next, this is the final benign tumor that we're going to talk about. This is osteoid osteoma or osteoblastoma. They are also relatively common. They are actually both the same tumor. Osteoid osteoma is the tumor which is small. It's less than 2 centimeters. Osteoblastoma is the same tumor that's greater than 2 centimeters. We divide them because they have different clinical appearances and different clinical presentation. Now, this is a classic board question. A young person comes in with pain at night that's relieved with aspirin, and they show you a bone tumor. That's going to be an osteoid osteoma. And that's because the tumor forms prostaglandins, and if you give them aspirin, the prostaglandin effect is reduced, and the pain goes away. This is as opposed to osteoblastoma, which does not respond to aspirin. Okay. All right, so you can look at this chart in your own time. This is a patella. It's showing you this well-circumscribed tumor. It often has a lot of kind of white sclerosis around it in osteoid osteoma. This is what it looks like under the microscope. This pink stuff is your bone. What do you think these cells are on the surface? Osteoblasts, perfect. Because they only have a single nucleus here. These are not atypical. They're just benign-looking osteoblasts laying down bone in this benign tumor. So now we're going to talk about some of the malignant tumors of bone. The most common malignant tumor of bone is osteosarcoma. Osteosarcoma is a tumor of young people. It usually happens in kids under 20. There is a small peak of osteosarcoma that happens in older people. The older peak usually happens in patients with Paget's disease. Remember we talked about how that predisposes you to osteosarcomas? All right, so these are the locations that you should be aware of. The most common place is distal femur and proximal tibia for osteosarcoma. Patients with mutations in retinoblastoma or the P53 can be predisposed to getting osteosarcomas. This is what it looks like on X-ray. You can see that we've got something going on. This is your tumor. It's broken out through the cortex, and it's got this thing. You can kind of see this white line. It's called the Codman's triangle, and it refers to the fact that the tumor, when it breaks through the periosteum, causes reaction of the periosteum, and therefore you get this, it's the periosteum that's lifted off of the surface. But anyway, so if you have a malignant tumor that's coming out of the bone, you know that's malignant, not benign. Here is another bone. You can see this big tumor. It's cut out through the cortex, out into the soft tissue. Nothing benign's ever going to do that. Prognosis for osteosarcoma depends on the stage and the grade of the tumor. So I will not expect you to, no one's going to expect you to know all the details about osteosarcoma. You are not pathologists. However, you are expected to kind of know the basics here. So whenever you see a tumor that's forming kind of pink stuff in the bone, that's more likely to be an osteosarcoma than anything else. Because this is osteoid. It has this classic pink appearance. This is immature bone being laid down by these really atypical cells in the background. Okay, this is osteosarcoma. So we're going to compare and contrast that with chondrosarcoma. Chondrosarcoma is the second most common type of sarcoma of bone. It usually happens in older people, unlike osteosarcoma, which we talked about in young people. Chondrosarcoma is a central process. C for chondrosarcoma, C for central. So the bones that are affected tend to kind of be the ribs, the spine. You can have involvement. If it involves like the knee area, it's going to involve the hips. Okay, it does not usually happen in the knee area. All right. So X-ray wise, a chondrosarcoma tends to be kind of radiolucent or black, right? Because it doesn't have calcification. It can have little flecks of white in it, flecks of calcification. But again, we're not going to give you just a radiograph and expect you to know what this is. You're not radiologists either. All right, so this is what it looks like when we cut it out. Here is a femoral head, because it can happen on the hip. You can see there's a fracture. You've got a diffusely infiltrative mass with hemorrhage. This kind of grayish stuff, this is cartilage. Cartilage, hyaline cartilage always has this grayish look on gross appearance. And it has cut through and it's out into the soft tissue. This is what it looks like under the microscope. If it's really well differentiated, you can tell it's cartilage. If it's poorly differentiated, you can't tell. So we grade it because the poorly differentiated ones do much worse than the better differentiated ones. So compare that to normal cartilage here. You've got a tiny little cell sitting in a space. This is chondrosarcoma. You have too many cells, and some of them are really big and ugly. So we are not going to spend a lot of time here. I will just tell you, you know that this is happening in the hip area. So based on location and age, you already are really suspicious that this is chondrosarcoma. So whenever you get a question on a test, look at the age, look at the location, try to use your common sense to see if it's benign or malignant before you decide what to call it. So all of these are benign, so it's not going to be those. It could be osteosarcoma or chondrosarcoma. This is chondrosarcoma because it's an older person. It's on the hip. Okay? So we're going to end talking about Ewing sarcoma. Ewing sarcoma is the most common tumor of the bone in young people. This usually happens in kids under 20. It has a very characteristic translocation. So there's only one translocation you ever learn. It should be the 1122 translocation of Ewing sarcoma. It is the EWS gene, which fuses to a member of the ETS transcription factor. And you make an oncogene, which is then stimulating proliferation of these cells. This is, again, you can't tell that this is Ewing sarcoma from the gross, right? All you can tell is that this is malignant. You can tell there's something infiltrating through the marrow. It's caused a break in the bone, and it's out in the soft tissue. This is malignant. This is what it looks like on X-ray. It's a little bit infiltrative. It's kind of cut out through here. Now, the prognosis, again, depends on where combined chemotherapy, the stage of the disease. This is what it looks like under the microscope. This is a small, round, blue cell tumor. When we say that, you've probably heard about this when it comes to neuroblastomas, retinoblastomas, lymphomas, or small, round, blue cell tumors. It just means that essentially all you see is the nucleus of the cell. You're not seeing a lot of cytoplasm here. Now, you can tell it may be Ewing sarcoma when it starts forming rosettes like this. The cells are kind of lining up around a central pink area. Okay. So, in general, when we talk about tumors of bone, if I asked you what is the most common tumor of bone, what will you say? It should be either a metastatic lesion or a lymphoma or a myeloma. Okay? So primary tumors of bone, like the osteosarc, chondrosarc we were just talking about, they are much less common than metastatic lesions in the bone. And the tumors that are most likely to metastasize to the bone, the mnemonic I've used is lead kettle. PB for lead, and then KTL. So prostate, breast, kidney, thyroid, and lung are the tumors that are most likely to spread. So this is showing you again a tumor out here. It's made up of clear cells. This happens to be a renal cell carcinoma. Just know carcinomas can metastasize to the bone, and that's much more common than a primary bone tumor. And that's all I have for this part.